This is week 3 in the interpretation and clinical application of common laboratory tests, and I'm your instructor, Jill Ellis. The learning objectives for today's lecture will be based on the overall course objectives. The first objective is to explain the physiologic importance of electrolytes. Today we will specifically be talking about sodium and potassium. We will also analyze the results of metabolic panels. The basic metabolic panel and complete metabolic panel both have sodium and potassium contained within them. We will formulate treatment plans based on the results of common laboratory tests. Specifically today we will talk about sodium and potassium disorders. The reading assignments for today's lecture are taken from your required textbook for the course, Harrison's Principles of Internal Medicine. I think you will find that the reading material that you have will supplement the course material that we will talk about in class today, as these are somewhat complex topics, and the supplemental material will give you a greater understanding of these areas. We will begin by talking about sodium. Sodium is the major extracellular cation. A cation is an ion that has a positive charge. Extracellular sodium concentrations range from 135 to 145 milliequivalents per liter. This is vastly different than the intracellular concentrations of 12 milliequivalents per liter. Serum sodium levels are assessed clinically by measuring serum sodium levels, which again are listed in both the BMP and the CMP. The concentration of sodium is determined by both the amount of total body sodium and total body water. You'll find as we go through the disorders of sodium that total body water deficits and/or excesses are most commonly associated with sodium disorders, much more significantly so than total body sodium alterations. Thus, when we talk about the homeostasis of sodium, we have to talk both about the sodium level homeostasis and water homeostasis within the body. Sodium has many important physiologic functions. Sodium is the major solute in extracellular fluid, so it effectively determines extracellular fluid osmolality. Chloride and bicarbonate also affect osmolality, but to a much lesser degree. Sodium works to maintain neuromuscular irritability, which is important for conducting nerve impulses. Sodium assists in the regulation of acid-base balance, and it does so by acting as a buffer through sodium bicarbonate and sodium phosphate. Sodium participates in cellular chemical reactions and membrane transport processes. As I alluded to, we'll talk both about sodium homeostasis and water homeostasis. Both of these topics are somewhat complex, thus I have created concept maps for you to assist in your understanding. I have abbreviated versions of the concept maps included in the PowerPoint presentation here. However, complete versions of the concept maps are available in the lecture content. Sodium homeostasis is maintained by two hormones, both aldosterone, which is the primary mineralocorticoid in the system, and antidiuretic hormone, or ADH, which also goes by vasopressin or arginine vasopressin, or AVP. You may see all of these abbreviations in your readings, thus it's important to be familiar with all of them. The end result of aldosterone levels is to increase serum sodium levels, and the end result of antidiuretic hormone is to decrease serum sodium levels. Thus, when serum sodium levels are low, aldosterone secretion increases. And when serum sodium levels are high, antidiuretic hormone secretion can increase. Water homeostasis is maintained through antidiuretic hormone, as we discussed, as well as the amount of water intake and amount of water loss. Antidiuretic hormone works to increase the water balance within the system by causing increased renal retention of electrolyte-free water. Water intake is primarily maintained through oral intake. The average oral intake for an adult is about 2.5 liters of water a day. Only about 1 to 1.5 liters per day is actually needed to replace urinary losses and insensible losses, such as things through sweat, through the GI tract, and through the breathing. Oral intake can be increased by stimulation of thirst and salt cravings. There is also some fluid that is generated from metabolic processes that contributes to overall water balance. Water is also lost from the body at a regular rate through renal excretion of water. Renal excretion of water is regulated through antidiuretic hormone, as well as renal function, and the amount of solutes contained in both the serum and the urinary system. There's also insensible water losses, as I had mentioned previously. Insensible water loss usually leads to about the 500 to 650 milliliters of water loss per day. This can vary, however, in certain physiologic states such as fever and/or environmental conditions such as hot weather. We will first talk about hypernatremia, or excess sodium levels. This is defined as serum sodium concentrations greater than 145 milliequivalents per liter. Hypernatremia is associated with hyperosmolality, or an increase of solutes per solution. This is because there's increased sodium per solution. Hypernatremia is usually associated with combined water and sodium deficits. This may at first seem counterintuitive. However, these patients do have water and sodium deficits. However, the water deficits are more significant than the sodium deficits, thus leading to an increased number of sodium in a decreased relative amount of water. Hypernatremia is much less common than hyponatremia, and that is because the body has good defenses against hypernatremia. Intact thirst mechanisms and access to water are the primary defenses against hypernatremia. Patients that do not have intact thirst mechanisms and/or do not have free access to water are the patients who are most susceptible to developing hypernatremia. Elderly are patients who are particularly at risk for development of hypernatremia. The etiologies of hypernatremia include things that increase water loss. This can be either through renal mechanisms or non-renal mechanisms. Renal loss of free water can be caused by diabetes insipidus. Diabetes insipidus is caused either by decreased circulating amounts of antidiuretic hormone or resistance to the antidiuretic hormone that is circulating. Osmotic diuresis can cause both hyponatremia and hypernatremia depending if the sodium or the water deficits are most predominant. If the diuresis is significant, leading to increased water deficits, then hypernatremia will occur. Osmotic diuresis occurs when there is an increased amount of non-reabsorbable or poorly reabsorbable solutes in the urinary system, leading to the excretion of water with those increased solutes. Non-renal loss can occur through GI loss, such as diarrhea, and increased insensible losses. Hyperaldosteronism can also lead to hypernatremia due to the increased retention of sodium. Excess dietary intake is rare but can also lead to hypernatremia. Clinical manifestations of hypernatremia are the same regardless of the underlying etiology. Signs and symptoms of dehydration are often present. Symptoms of hypernatremia are predominantly neurologic. This is because the hyperosmolality of the serum creates an osmotic gradient between the extracellular fluid and the intracellular fluid, leading to the loss of water from the intracellular compartment into the extracellular compartment. This leads to cellular shrinkage and predominantly results in neurologic symptoms. Altered mental status, such as confusion, lethargy, irritability, and weakness, are early signs. Hyperthermia, delirium, seizures, and coma can develop with more severe hypernatremia. Clinical evaluation of hypernatremia begins with comprehensive patient evaluations to identify the underlying etiology. It is important to determine if the underlying sensation of thirst is present or absent, to identify the source of fluid loss, which is likely present, clinically assess the volume status of a patient, and perform a detailed neurologic exam. It is important to assess not only the serum sodium levels, but also other serum electrolyte levels, as other electrolyte disorders can coexist. Assessment of urine osmolality can help to identify if the kidneys are responding appropriately. The appropriate physiologic response to hypertonic hypernatremia is an increase in the circulating antidiuretic hormone with subsequent excretion of very low volumes of dilute urine. If the underlying etiology is due to disorder of antidiuretic hormone, such as diabetes insipidus, this response will not be seen. Treatment of hypernatremia is based on identifying the underlying etiology and correcting it, and slowly replacing the fluid and electrolyte deficits. You do not want to do this too rapidly, as complications can occur. In general, you want to replace the fluids over approximately 48 hours, with a goal of decreasing serum sodium levels by approximately 1 milliequivalent per liter per hour. You can do this through administrations of various types of IV fluids, or oral or nasogastric fluids in less serious cases. Complications of hypernatremia include cerebral edema if the serum sodium is corrected too rapidly. Mortality rates can be substantial for hypernatremia, and it is felt most commonly to be due to the underlying etiologies. We now have time for a couple discussion questions. Sodium disorders are most commonly due to which of the following? Water imbalance, sodium imbalance, both sodium and water imbalance, or none of the above? The answer is water imbalance. As we had stated during the lecture, both sodium and water imbalances can lead to sodium disorders. However, they are most commonly due to water imbalances. Next, which of the following most commonly leads to hypernatremia? Excess total body sodium, excess total body water, total body sodium deficiency, total body water deficiency, both A and B, or both C and D? And the answer is total body sodium deficiency and total body water deficiency. However, as you recall, the total body water deficiency is more significant than the total body sodium deficiency. We now have time for a couple of questions and answers, and then we will move on to part 2 where we will discuss hyponatremia.